Hi everyone, my name is Manvi Koduri and I'm a junior at Clarksburg High School based in Clarksburg, Maryland. Today I'm incredibly honored to be able to present my research and I'll be diving deep into a topic that's both technically complex and personal for anyone interested in cardiology and medicine in general. So today I will be discussing how different types of patch materials impact the short and long-term outcomes for patients with congenital heart defects. I had conducted this research under the mentorship of Ethan Shervonsky, who is a current medical student at NYU Stern. So, yeah. My research explores not just what performs best on paper, but what it means for real children living with lifelong conditions. So, about 40,000 babies are born each year in the United States with a congenital heart defect. That means roughly one in every 100 births. And globally, we're talking about over 1.35 million infants annually. These are numbers that we simply just can't ignore. But thanks to medical and surgical advances, survival has improved dramatically. But we have to think about the future, the long-term outcomes. It's not just about keeping a baby alive, but it's about whether that child grows up without having to undergo multiple reoperations, experiencing patch-related complications, or facing lifelong limitations. That's where material matters. For my research, I focused on three patch types: synthetic, animal derived, and tissue engineered. And I analyzed them based on five key metrics: the biocompatibility, native tissue integration, growth potential, durability, and cost. These factors don't just influence medical success, but they shape an entire patient's future. So, to build out a solid evidence based comparison, I carried out a systematic literature review covering nearly 25 years from 2000 to 2024. I pulled peer reviewed studies from PubMed, Medline, Scopus, and I even utilized Google Scholar. And some key terms that I included were patch material, congenital heart defect, and postoperative outcomes. And I focused specifically on human clinical trials with sample sizes over 30 to maintain that reliability factor. I excluded single patient case reports and non-English publications and animal-only studies. I also included retrospective and prospective studies, including follow-ups ranging from 1 to 20 years and both pediatric and adult populations. So how do cardiovascular patches work? Cardiovascular patches are bioengineered materials that are used to repair or replace damaged heart tissue. They function by providing mechanical support to the affected area, promoting tissue regeneration through the activation of the body's natural healing processes. And in some cases, they serve as delivery platforms for therapeutic cells or growth factors. This multifaceted approach enhances cardiac function, ultimately facilitating tissue integration and reducing the risk of further deterioration. So here I have an example of cardiovascular patches that could be utilized, in myocardial infarctions. The pathophysiological progression for myocardial infarctions can be delineated into four distinct yet overlapping phases, including early acute injury, inflammatory response, tissue proliferation and repair, and adverse remodeling stage. Understanding the specific pathophysiological mechanisms of each phase can inform the formulation of treatment targets and strategies. Keeping that in mind, the utilization of cardiovascular patches is unique to every single scenario. It is important to keep in mind that what may work for one patient won't necessarily work for another. So here, this table summarizes how the three major patch types stack up across my five core evaluation criteria. Let's go ahead and unpack it. This slide basically just sets the foundation for what I'll be breaking down next. So synthetic patches, including EPTFE and Dacron, are reliable in terms of mechanical strength and cost efficiency. However, their biocompatibility is limited, meaning that they don't integrate into native tissue. That makes them susceptible, to infection, fibrosis, which is ultimately the excessive accumulation of connective tissue, and eventual failure. And most importantly, they don't grow with the patient. Animal-derived patches, mainly bovine pericardium, which is interestingly a tissue obtained from the outer layer of the heart of cows, offers improved compatibility and they handle well during surgery. But still, they eventually calcify and they also lack the ability to grow. Tissue engineered patches, on the other hand, are being considered the new frontier of medicine. Their biggest strengths include integrating seamlessly, having the potential for growth, and they almost show no signs of late-stage calcification. But the only drawbacks is that they're expensive and they're still under long-term review. So synthetic patches are often the go-to option in many centers, largely because of their reliability and affordability. ePTFE, commonly known as Gore-Tex and Dacron, are used extensively, particularly for high-pressure repairs like those in the right ventricular outflow tract. They resist thrombosis and they maintain the shape under any hemodynamic stress. But the body treats them as foreign objects. They don't remodel, they don't integrate, and they don't grow. A 2019 multi-center study found that patients with synthetic patches had a 25% reoperation rate only within 10 years. This is primarily due to the lack of growth or even patch degeneration. Moreover, studies have reported infection rates ranging from 6 to 12% and delayed rupture events even decades later. So while synthetic materials are strong structurally, their biological performance leaves a lot to be desired from patients and surgeons. So sorry, bovine pericardial patches offer a biologically closer alternative. Their texture makes them easier to handle and suture, and they tend to be better tolerated by the body's immune system. That said, they still don't integrate like native tissue, and their lifespan is very limited. In pediatric patients, calcium deposition is a serious issue. One European registry reported that calcification related degradation in 14% of patients within 8 years. Also, because this material doesn't grow, repeat surgeries are almost guaranteed in infants and toddlers. But compared to synthetic patches, they do reduce early postoperative complications and seem to hold up slightly better in midterm follow-up studies. So, tissue engineered patches are revolutionizing pediatric cardiac surgery and cardiac surgery as a whole. Basically, these are scaffolds often made from decellularized animal tissue or biodegradable polymers that encourage a patient's own cells to infiltrate, remodel, and regenerate the patch into living tissue. So, CardioCell is a standout example of a tissue engineered patch. In a 10-year Australian study, patients with CardioCell patches had zero cases of patch related infection. They had minimal calcification and complete cellular infiltration within only 24 months. What makes this technology transformative is that these patches have the ability to grow, what we haven't seen in bovine patches and synthetic patches. They remodel in step with the child's development in cardiac surgery. Their only drawback is that they're very expensive. They often exceed $2,000 per unit, and also we don't have the 30-year durability data, so we can't tell how they would perform long term. But early and midterm results suggest that they may drastically reduce the need for reoperation, especially in pediatric cardiac surgery. So here's where things get complicated. So while synthetic patches are budget friendly at around $200 to $500 each, bovine patches cost almost double. Tissue engineered patches can exceed $2,000. That pricing excludes surgical costs, hospitalization, or long-term follow-up. In low and middle income countries, that cost gap becomes a significant barrier, not just to innovation, but to equity. Many cardiac centers in LMICs are forced to rely on older technologies, even if they know the outcomes may be worse. As of 2023, fewer than 10% of CHD surgeries in sub Saharan Africa use tissue engineered materials. The ethical question becomes, how do we expand access to life changing technologies without exacerbating global healthcare disparities? Here's what the data tells me. In pediatric populations, especially infants, tissue engineered patches should be the first choice whenever feasible. Their growth potential and integration capacity significantly reduces reoperation risk. For adolescents and adults, synthetic and bovine patches remain viable, especially when growth isn't a concern and tissue integration needs are lower. But overall, I believe we need to push not only for clinical adoption of tissue engineered patches, but for innovations in how they're manufactured and distributed. Cost reduction strategies and partnership with global health organizations could make them accessible all around the world. So, to wrap it up, There is no single best patch for every patient. It's unique to every patient. Each material has its trade-offs, but the potential of tissue engineered patches has the opportunity to grow, integrate, and reduce long-term complications, making them an incredibly exciting innovation to look forward to. But based on my research, I have realized that we still need more studies to justify the effective uses of these patches. Most importantly, we need to rethink how we define success. It's not just in terms of survival, but in giving every child with a congenital heart defect the best possible life and their best possible follow-up terms. Thank you so much for your time, and I'm happy to take any questions.
Incredible. Thank you so much. Um, I think it's always a mark of a great presentation that you already answered the question that I had for you, which was around like the economics and access. And
Mm,
so that's always really like, impressive when you've kind of like
thank
put
you.
yourself in someone's headspace like that. Um, I'm curious, do you have a sense of how much and like even from what the patches have evolved? Like what did like early prototypes look like?
So, according to like the studies that I did, I picked out a lot of studies ranging from the year 2000 to 2024. So in 2000s, we saw a lot of synthetic patches. Synthetic patches have been the norm for so long. So we've only seen, tissue engineered patches. They're post-operative and like we still see them evolving, but initially like synthetic patches were considered the structure.
Fascinating. And were they always made out of kind of the same material or okay, yeah,
Yeah.
interesting.
So, like I mentioned, like Dacron was a really big material used for synthetic patches, and we see that being used in the year 2000, even to this day. So, it's been pretty effective.
Yeah, yeah, interesting. But also room for improvement and not the most
Yeah, yeah,
effective.
for sure.
Fascinating. Okay, wonderful. So it looks like there is a question for you too in the
Okay.
Q&A. I'll let you go ahead and just type an answer to that just for time for our next two presenters. But thank you so much for sharing with
Thank you so
us.
much for your time. Thank you.
Oh my gosh, I loved it.